we will like to sort of discuss cases in detail so that at the end of the day, you are wiser for it, and we have reached a certain amount of level in our presentation. Okay. So these are the things, that we should, and these sessions will be as interesting or as useful as you would want us to make them. So what you have to be trying is to do good presentations. It's not that you just do some kind of a formality. You should do a good presentation wherein you just come thoroughly prepared. Come thoroughly prepared and try and make a good history, good presentation, and take the help from the books. It's like when you know that you are going to make a case presentation 2 or 3 days in advance, then you should take a good history, do a good physical examination, write down your history, edit your history, and make it clear so that you are passing on a very decent message. You are passing in a message which is clear and which is unambiguous. So these are things that we should be doing. And once we have started these sessions, we'll probably like to go on till you guys have your final exam, and that should be somewhere maybe after in the month of July or August. We'll continue with these sessions and we'll try to bring in more discussants and more faculty. So not that every time around I will be the faculty. There'll be some of my friends and some of our colleagues who will act as faculty, so that you can get teaching from a cross section of teachers, and that way the interest will remain, and I also will not get overburdened that I have to be doing every session myself. So we will go in for quality. Just a minute, I'll have to take this one. I'm back with you now, and I'll request every one of you to keep your phone on the silent mode and try not to get distracted by this. With these opening words and with the um, sense of, or with the intention of saying good luck to you guys, because I think ultimately end of the day, all these sessions are meant to help you pass your exam. So I wish you all the very best, and I do hope that we will have an auspicious beginning. Over to Dr. Shyam for his presentation.
Very good evening, sir. I'll start with the case, sir. A 22-year-old lady who's unmarried, who's a student, graduate, final year graduate from a lower middle class family, came with complaints of lump in the left breast for 3 years duration. Coming to history of presenting illness, the lump was insidious in onset and progressive in size. The lump was incidentally noticed by the patient 3 years back. There is no history of pain, no history of discharge from the nipple, no history of trauma, there is no history of fever, there is no history of loss of weight or appetite, and there is no history of any breathlessness, cough, or bone pain or jaundice present. Past history.
No, I think
No.
let's I think look at this history, and whether we are happy with this history or we are not happy with this history, what more we should have in the history, right?
Yes, sir.
So now can you summarize your history, please?
We have a 22-year-old unmarried lady, student by occupation. She came with the complaints of lump in the painless lump in the left breast for 3 years duration.
So this patient is having a painless lump in the left breast of 3 years duration, right?
Yes, sir.
And it is increasing in size, as you said, it is progressively increasing in size.
Yes, sir. Yes, sir.
So what is the you should tell us what is the size which was observed at the time when the patient noticed this lump for the first time, and what is the size now?
So now the current size is approximately 3 centimeter, which is an inspection, sir. It is palpation, which it was found at approximately 3 into 3 centimeters. Initially, it was very small, and in the last 6 months, she is told that it is progressive in its size, sir.
Mhm. Well, okay. So you think that this lump has been kind of static in terms of its growth, and the past month or so it has started increasing a little more rapidly.
Yes, sir.
Okay. Uh, what do you think is the normal size of a lump that our fingers can feel in the breast?
More than 1 centimeter, sir.
More than 1 centimeter is everywhere. I think half a centimeter lump we can feel anywhere. No, not less than half a centimeter lump we can feel. More in the breast, it all will depend upon the bulkiness of the breast. So I think even 1 centimeter lump may not be palpable in a very bulky breast. But if the patient is having a breast of an average size, then you are right. It could be about 1 centimeter or the size of a marble or thereabout. Right.
Yes, sir.
Okay. So I think in a 22-year-old patient, if you find that the lump is giving a history of rapid progression for a month, what will be your thought process? What do you think could be the reason for it?
Any, sir, any component of fibroadenosis, sir?
Fibroadenosis lumps would be painful. So you are wrong in the beginning.
Malignancy, sir.
No, listen. Now I think what you said. I think this is very important. This is a session, where we have to correct some of the misconceptions that you may be having. When the patient has a painless lump, right? By and large, fibrocystic disease is not in consideration. Remember that. Fibrocystic disease would mean pain, right?
Yes, sir.
And what is the next symptom?
Only lump, sir. There is no other.
No, pain,
Uh,
uh,
no discharge, sir. No discharge.
no discharge.
No history of trauma.
No, fibrocystic disease. What are the
Oh,
symptoms that a patient
sir,
of fibrocystic
cyclical changes, sir. Cyclical pain, sir. During.
pain and nodularity are the two important symptoms in a patient of a fibrocystic disease. They generally do not have a palpable lump unless they have a large cyst and a complicated cyst. Okay.
Yes, sir.
And what is the age at which fibrocystic disease peaks? What
Uh,
is the age distribution of fibrocystic disease?
15 to 35 years, sir.
Not 50. It is a disease, which generally occurs after multiple during the time of pregnancy and multiple pregnancies when there are hormonal changes are occurring in a very rapid sequences or very widely. So generally about 30-35 would be the year, and generally what we see is the patients who are premenopausal in the early, I mean, they're between 35 to 45 years. That's the time, we get to see these patients. And more importantly, menopausal patients, you should not consider the diagnosis of a fibrocystic disease. Now, you remember, if this is a very important rule of thumb, that fibrocystic disease is generally a very uncommon entity to be seen in a menopausal patient.
Yes, sir.
And pain is the most important, factor or most important system that should direct your attention to the possibility of a fibrocystic disease. Okay, so now in this patient, what do you think would be the reason for this lump increasing rapidly?
Sir, malignancy, sir.
No, a 22-year-old uh, uh, woman, a 22-year-old girl, you consider the diagnosis of malignancy on what basis? Because simply because the lump has increased rapidly in the month, you will consider that is the reason?
I mean, no other, nothing
What?
others suggest that.
Huh?
I mean, no other symptoms suggest of malignancy except the rapid increase in size,
Wha-
sir.
Rapid increase is also not that rapid increase, number
It is. I
one.
mean, it is not that. I mean, it was almost like it's a 3 centimeter. Initially, it was like two centimeter. Then it
So,
was like 2 to 3.
my
Not that
dear,
much, sir.
my dear, if you have a patient who is 22 years of age, you should take a gulp of salt before you decide that I'll offer the diagnosis of cancer. First, I'm not saying that it can't be cancer. We now know that cancer can occur quite early also, but you should think of something else. If anybody would want to give any kind of differential diagnosis from the audience, anybody can raise his or her hands and answer that question? Has somebody? This is Dr. Rakshit. No, giant fibroadenoma. Okay. Yes, I think you should think the possibility of a fibroadenoma, that is kind of giant fibroadenoma or a cystosarcoma phylloids. That's the kind of thing that you can consider. But more commonly, it would be something like a cyst, which could get complicated, or where some bleeding can occur and the patient can get a feeling of an enlarging swelling in the breast, enlarging lump in the breast. So these are things. Yeah. So degeneration is generally not a common phenomena in the fibroadenoma, and as for this uh, differentiation between fibroadenoma and cystosarcoma phylloids concerned, that is about 3 centimeter is the cutoff. If there's more than 3 centimeter, then consider the possibility of giant fibro. This considers the possibility of a cystosarcoma phylloides. So you remember that it's not simply if the thing is increasing rapidly in size, the common tumor in this age group is fibroadenoma, right? And fibroadenoma can grow rapidly if it's having some kind of a cystosarcoma phylloides change, or it is kind of fibroadenoma which is heading towards a giant fibroadenoma formation. So that's one. So, changes like some kind of a bleeding into the cyst is another possibility. So these are things that you should consider, and absence of pain would suggest that fibroadenosis is not a common consideration in this patient. Okay. So what is that now in the history that you would like to say? Somebody has written calcified traumatic fat necrosis. Do you agree with this diagnosis?
Usually it is painful, sir.
Generally, when does the fat necrosis occur? If you look at the patients,
Trauma, sir, history of trauma.
no, anything else? Anything else?
Mm.
When does, what are the components of the breast? There is a
Sir,
ductal system, there are ducts, there are lobuli, there is a
stroma.
stroma. So where does the fat come from?
Stroma, sir.
No. Stroma becomes fatty only in the postmenopausal stage. So the breast has to have a lot of fat, to have fat necrosis. So it is generally the history is like this, that a woman has been playing around with her grandchild, and that grandchild happens to sort of kick her breast, and that kind of a trauma triggers a situation of a fat necrosis. Right. So the breast has to be fatty, and that fatty breast happens only in the postmenopausal state.
Yes, sir.
These are simple things, but these are very, very important, and they are very well understood, right? So, immediately in one instance, we have told you that what is the age, what is the characteristic of the patient who develops a fat necrosis, right?
Postmenopausal.
Postmenopausal patient, right? That's postmenopausal patient. The stroma becomes there is a sort of involution of the ductal system, involution of the uh, acini, lobules, and they are replaced by fat. And this is the fat which undergoes necrosis, and that becomes calcified, and that what presents as a lump. Okay, so remember that kind of a thing. That is, fat necrosis is an entity which you should only consider in a postmenopausal. Okay.
Sir, even PASH, pseudoangiomatosis stromal hyperplasia, that is
Huh?
also pseudoangiomatosis stromal hyperplasia, PASH.
The anybody would like to agree or disagree with Dr. Sham Rangan? Who would like to agree or disagree with Dr. Sham? I will disagree with you. And the reason for that is that these exotic diagnoses are the diagnosis, pathological diagnosis. They are not clinical diagnosis, and one should never make a pathology diagnosis on just to impress the examiner. You should always make simple diagnosis, right? And don't consider these so-called angiomatous malformations or things like granulomatous what's called
Idiopathic
non-tuberculous
granulomatous.
granulomatous atypical tubercular disease or whatever they call it. Now, that's called granulomatous granulomatous mastitis.
Idiopathic granulomatous mastitis.
Idiopathic
Granulomatous mastitis.
granulomatous mastitis. So these are things which you should only consider only after you have got the pathology diagnosis. You not just simply just jump onto the thing. Okay, I know this entity and I'll propose this as a diagnosis. No. So it's a young patient. Other than lump, she doesn't have anything else in the history. Now, what is more that you need to know about this patient in history and about it about her?
Sir, I'll continue the history, sir. There is continue.
Yes, what more do you want to know? What is that you want to, which can give you some kind of a lead to the diagnosis?
In investigations, you are asking.
No, no, history only, history.
History of smoking, sir.
History,
History of
family
smoking.
history, or whatever.
The family history of any malignancy, cancer.
Yes. So that's very important. If a young patient comes with a lump and, if there is a family history, that adds another dimension to the consideration of diagnosis. So if the patient says that her mother or her maternal side or on the paternal side, there is a history of breast cancer. And what are those breast cancers which are, considered to be hereditary? Have you an
Usually
idea about, huh?
BRCA associated. BRCA
No,
associated.
no. In clinical, we are only talking clinical. Anybody would like to answer this question? Anybody? A cancer occurring in a premenopausal woman in the family, right, at a younger age is the one, which comes in the category of a possible hereditary type of cancer. So it's a younger patient, cancer occurring in a younger patient, premenopausal patient. So that's what becomes important. A postmenopausal cancer would not have that kind of significance as a premenopausal cancer, breast cancer would have, and that will have to be in a, either on the mother side or on the father side. Even if on the father side, there is history of this. Hereditary cancer, even that is also quite important. You got it?
So we should also ask
Anybody?
history of ovarian cancer, history of any pancreas tumor,
Yes, all cancers should be asked,
all
but
cancers.
history of breast cancer in a premenopausal relative, which is first degree relative, would be extremely important.
Yes, sir.
Okay, so remember that. So of
Yes, sir.
course she is a young patient, and there is in an elderly patient you would always have taken the history of use of hormone replacement therapy and these oral contraceptive pills. But that's that. Somebody has written BRCA. Yes, BRCA is the way, but all cancers, all hereditary cancer, only 10 to 15% are due to BRCA. Others are not due to BRCA inheritance.
So there's a question. Can you please explain the reason for jaundice being asked as a negative history? That is mainly for ruling out any metastasis. History of any breathlessness, bone pain, or jaundice is to rule out any metastasis.
You see, when a cancer diagnosis is not on your radar, then it is better to to just put in review of symptoms, review of systems, ROS. In the review of systems, you can always mention that GI, the musculoskeletal, right, and CNS, CVS are all negative for any kind of complaints. So review of symptoms, review of systems have to be always there in every case. but specifically mentioning jaundice and specifically mentioning all those symptoms, that we see in patients of metastasis, in patients of breast cancer, metastatic to various regions, that is not specifically needed in this patient.
Yes, sir.
Because our diagnosis is not cancer here.
Yes.
On history, our diagnosis is not cancer. We'll be surprised if it comes out as a cancer. But yes, we will generally, take it to the logical conclusion. So, does that answer the question? Review of systems should be done in every situation. It should include CNS, it should include GIT, urinary symptoms, and musculoskeletal system. Every system should be looked at in a thorough manner, right? That is something which is absolutely necessary for every patient across all systems. Then you give importance in a patient where you are considering the diagnosis of breast cancer. If you are, suppose you are considering the diagnosis of breast cancer in this patient, and then you mention, that okay, these symptoms are absent in this patient, or these symptoms are present in this system, that becomes important. So let's ask you, in not in this patient, but in another patient, 45 years of age, with a hard lump in the breast, okay, what symptoms you would ask for in to rule out or to sort of have an idea whether the patient has any kind of a metastatic manifestation?
Sir, metastatic manifestation, most common is history of bone pain, sir. Any spine pain, bone pain. That is the most common place for metastasis, the lumbar vertebrae.
Uh-huh.
Then history of any breathlessness, sir. Any involvement of lungs, or any history of cough present. And if it has metastasis to the liver, then we can ask history of jaundice, sir.
Now, I think, if can you answer my question like this? What are the common sites to which breast cancer metastasizes?
So number one is the lumbar vertebra, sir.
Huh?
The lumbar vertebra.
Number one is lumbar vertebra. Okay, bones.
Bones,
And bone may it will be axial skeleton. Okay,
axial skeleton.
right. And then two,
Lungs, sir.
two is lungs. Three,
Liver.
liver. Four,
CNS, sir.
brain.
Brain.
So if you are to ask the history, then your the most important thing would be bony aches and pains, especially backache, and with backache which started after the patient noticed an index lesion in the breast. That would be the kind of thing, that would uh, give you an idea that okay, we may be dealing with bone pain, which could be of metastatic origin, and the disease being breast cancer. As far as lung involvement is concerned, that will be manifesting in the form of cough. Most common thing is cough, hemoptysis, and this dyspnea, right? A dyspnea when there is pleural effusion due to malignant involvement of the pleura. As far as the liver is concerned, it is a very forgiving organ. 7/8 of the liver may get destroyed for the patient to develop for the patient to develop jaundice, right? So the huge amount of liver has a huge reservoir, and huge amount of liver should get knocked off for the patient to develop jaundice. So jaundice is a very poor marker for a possible metastasis to the liver. But you have to ask the history, no doubt about it. So when you are looking for metastatic involvement, then ask the symptoms in these sequence: the bones, the respiratory symptoms, and then of course you can ask the history of jaundice or presence of any lump in the abdomen. And don't forget, jaundice and involvement of the peritoneum and Krukenberg tumor. These are all a possible manifestation of a breast cancer. And then of course CNS, and you should definitely ask the history of any change in the higher mental functions.
Yes,
Got
sir.
it?
Coming to past history,
Somebody's asked lump in the other breast,
there is, I mean, in history, there is no complaints of any lump in the other breast.
but it is very important. It should always be asked. So here, I know this is a very simple case, and diagnosing it is not going to be some kind of a rocket science. It's very simple. But here we are discussing, how to approach a patient of breast lump in various combinations and permutations,
Yes,
right?
sir.
And how to make a good story out of it. So that's the whole purpose of this exercise. This is not a very difficult diagnosis that we're going to make in this patient. It's a simple thing, and it will be a simple, discussion if we just stick to this lump in a 22-year-old woman. But we are enlarging the scope so that we can cover various permutation and combinations of presentation.
Yes, sir.
Okay. So
Moving
that's
to the
regarding the metastatic history.
yes,
If
sir.
there's anything else that we need to know.
Sir, shall we go into the more past history, sir?
No, no, let's talk
Mhm.
about the history. In this patient, it is not so important, but
Sir,
in every
history of
patient,
history of
you would need to have an understanding
alcohol
about
intake.
performance status of the patient. So at one point or the other, you should know that you will find out the performance status, and that will be a combination of your inquiry into what patient is doing, and what patient is, or is she generally bedridden or whatever. So you should understand that when you are dealing with a patient of breast cancer, you would be required to know about the performance status. And there are, what are the ways of knowing the performance status, or what are the various scales which are used for assessing the performance status.
Karnofsky scale is used, sir, and
What,
other common for malignancy ECOG score is used, sir.
what is ECOG score?
ECOG score,
What is that?
European,
Huh?
Eu- European or ECOG.
So I think basic message that I want to give you is that you should know about the performance status. Forget about it. Forget about it. Even I don't remember offhand. So it's not that you need to know everything. It is important is that you should try and understand that this would be one of the consideration that we'll have in a patient of breast cancer, and that we should know exactly. And also more important is in all other cancers, especially GI cancers, whether when you are planning to have a major surgery, you would always need to know about the performance status. In breast cancer, by and large, systemic manifestations occur very late when the patient is having a very huge burden of metastatic disease, right? In early stages, let's say in the early breast cancer, even in advanced breast cancer, there is hardly any kind of you know effect on the overall well-being of the patient, and the performance status remains quite good till the patient is in even in stage 4. Some of the patients in the metastatic group also do not have much of a constitutional symptoms, and much of an effect on the performance status. It is only in GI malignancies, and hemato-oncological malignancies that, these things become important. But you should know the scale, Karnofsky scale, and also
ECOG
ECOG
scale.
scale. These are important scales, and you should be able to, use it even in every situation. Because why do we need to understand this? Because every patient undergoing major surgical resection requires to be fit, and it is these scales, which tell us whether we can offer the surgery or not. If our patient is not having a good performance status, even if the disease is resectable on the imaging, it is considered to be non-operable situation. Okay,
Yes,
so
sir.
that's a thing that you should remember, and that's something which should be well understood. That in every patient you should try and ascertain the performance status. And why the performance status is ascertain? Because before you offer a patient a major surgical resection, he has to be in a good performance status. That is, he is not bedridden, and he is kind of uh, capable of going up to washroom and taking care of himself to that extent. If he's a bedridden all the time, and he is uh, needing all kinds of help, then he is not candidate for
Surgery.
surgery per se, unless of course you can build him up, and that will be a different call one of these days. We may probably discuss that. Sometimes the patient comes to us, if the performance status is poor, and we know that okay, we can improve the performance status, and then we go in for improving the performance status. Sometimes we are happy improving the performance status, patient's status improves, and then you can offer him the surgery at that time. A very important thing is coming out these days, and that is called as sarcopenia.
Yes, sir.
Sarcopenia in GI malignancies is considered to be a great marker about the possible outcomes of the patient post-surgical. So I'd like you to read something about the sarcopenia. What does it mean, and how to sort of factor that into your patient's decision. Okay, chalo, next.
Yes, sir. Coming to past history, no history of diabetes, hypertension, or tuberculosis. There is no history of previous surgery. There is no history of drug intake or any OCP intake. Family history, no similar history in the family. There is no history of any malignancy in the family. Coming to the personal history, history of vaping present, sir. Then history of alcohol intake. She takes vodka, that 3 to 4 pegs in a month, sir. Once a month, she takes alcohol.
Mm-hmm.
Menstrual marital history. She is unmarried. She attained menarche at 12 years old. She has regular cycles, 28/3 cycles. Her LMP was 2nd May 2023. Now, I'll just summarize the history, sir.
I think we got, okay, you can quickly do it.
So here we have a 22-year-old lady who is unmarried with the complaints of a painless lump in the left breast for the 3 years duration, which was insidious in onset and progressive in size.
Mm-hmm.
Yes, sir. Coming to the general examination, patient is conscious, oriented, comfortable with Karnofsky scale 90.
Yeah. So now why not 100?
So she has some signs, sir. Some signs is Karnofsky scale 90, sir. Without any.
Is the disease restricting her life? Is the disease restricting her life?
Sir, if it is restricting, it comes to 80, sir. If it is not restricting, she is able to carry out all her activities, but some signs and symptoms, it is 90, sir.
I think we have to be very clear. So I would not sort of enter into an argument here, but you should read it thoroughly and understand that Karnofsky, you should be able to assign a Karnofsky, which is given in the standard books. Okay.
Yes, sir.
Okay. Let's leave it at that.
Yes, sir. No pallor, icterus, cyanosis, clubbing, or any lymphadenopathy or edema present, sir.
Mm-hmm.
Her vitals, blood pressure is 120/70 millimeter mercury. Pulse rate is 83 per minute. Her saturation is 98% in room air.
Mm-hmm.
Yes, sir. Coming to the examination of breast, the proper consent was obtained from the patient. The patient was examined in a well-lit room and with a sister beside me. On inspection, patient was examined in sitting position. Sitting position. Her breast was bilaterally symmetrical. No mass or ulcer seen. There was no dilated veins present. Nipples, there are 2 in number, bilateral side, and nipple and areolar complex was normal. In
two
inspection,
nipples? She had 2 nipples.
I mean, bilateral. I mean, bilaterally, sir. Like
the 2 nipples bola tune.
I mean, one nipple, sir, on right and left, sir.
So see, when you examine the patient and the patient is sitting, right? What are the things that you look for? What are the things that you look for?
Any lump, first asymmetrical, sir. Symmetry present.
First is you look for the symmetry. That's right. And that symmetry, if it is, asymmetrical, then you know exactly where could be the possible problem. You can look, what else do you see?
Any dilated veins or ulcer present, sir?
No,
skin. Any skin changes, sir?
Areola and the nipple, right?
Yes, sir.
Areola on the 2 sides and the nipple, they should be symmetrical. You will also look for any retraction. Now remember this, retraction or inversion of the nipple is also to be seen at this time when the patient is sitting with her maybe arms on the hip, or just simply sitting in front of you. So that's the time when you look for. And don't forget, you would always ask her to raise her hands over her head to look for any changes in the texture of the skin. The puckering and dimpling signs of early malignancy can only be seen, if you have a situation when you ask the patient to raise her hands over her head, and there is a differential movement between the skin and the breast. And if there is tethering is a pathological situation, or tethering is a, let's say, a change that has happened which results in puckering or dimpling of the overlying skin. So, puckering or dimpling is a sign which you will elicit, and the cause of that sign is tethering. Got the point? And tethering means that there is some kind of attachment between the, dermis and that particular lump, which is abnormal, and therefore it is not move. It cannot move the. It cannot move in the normal way, right? If there is no tethering, it will be able to move. But if there is something, which is holding it, it will not be able to move. So
Yes, sir.
that is what will be the reason that what happens. What is the tethering due to? Can anybody tell me what is the cause of
Sir,
tethering?
the involvement of the ligament of Cooper, sir.
Huh?
Sir, I mean, along the ligament of Cooper, the skin is pulled, sir.
What is ligament of Cooper?
Sir, it is the longitudinal attachment between the skin and the subcutaneous tissues.
Anybody who can give a better description of this Cooper's ligament? Anybody? Nobody is raising his hand. You understand the Cooper's ligaments are suspensory ligament of the breast. They stretch from the dermis to the pectoral fascia. Okay, and they are the ones which give the shape to the breast, and they are the ones which are attached to the lobules. Okay, you got the point.
Yes, sir.
So when there is an involvement of the Cooper's ligament by the malignant process, there is fibrosis. As that fibrosis occurs, which is called as which is called as fibrosis induced by infiltration of these ligaments. So there is a shortening of these ligaments. As a result, that part of the skin in that region and the lump, they become fixed to each other, and therefore that when you move that lump or when you move the skin, lump will not move but the skin will move. So there is going to be that puckering that will be seen. Got the point?
Sir,
So
usually they tell puckering is on palpation and dimpling and tethering in inspection, sir.
tethering is the reason for all of these. Tethering means that it is being held back, right? Tethering means it's being held back by something, like you have a buffalo, and you just can sort of uh, have him on one of the you anchor a buffalo to some pillar or somewhere, so buffalo can only move around that.
Yes,
So
sir.
tethering is because of that particular situation.
Yes, sir.
So uh, tethering, then puckering, and this all, because these are all signs of malignancy, and they do not change the local T stage of the tumor. Now, you remember that particular thing. The T stage of the tumor depends upon so many other stages, but tethering doesn't change. So, while we are talking about these signs, we should also talk a few more things, which are important, of course, not in this patient, but overall. And what is, we mentioned about the involvement of Cooper's ligament resulting in puckering of the skin, which is accentuated when we ask the patient to raise her hands over the head, right? The, uh, the skin will move, but the underlying lump will not move, and it is held back by that ligament. Okay, got the point?
Yes,
So
sir.
that's one. Second is retraction of the nipple. Now, I think that one should understand retraction of the nipple very clearly. Retraction of the nipple of recent origin. There could be retraction of the nipple, which is there for so many years. Retraction of the nipple of recent origin is very important. Retraction of the nipple after the patient has seen the lump, then it is important. Okay. So, and retraction of the nipple will generally happen in two ways. Whether the retraction is due towards the lump, whether the nipple is getting pulled towards the lump, it is because of the fibrosis. If it is getting pushed away from the lump, it is because of the pressure effect, right? So nipple position, this will not be retraction. Retraction is always towards the lump. Retraction
Yes,
is
sir.
always towards the lump, but the nipple can get pushed away from the lump or towards the lump. If it is getting pulled towards the lump, it is a phenomena because of the fibrosis of the lactiferous cyst, lactiferous ducts, right? And these lactiferous ducts get involved by the malignant infiltration. Malignant infiltration of the lactiferous duct can pull the nipple towards itself. Okay. Whereas if there is a large lump, like a lump of cystocytoma phylloides, now this phylloids tumor lump is a large lump. Has it? It doesn't cause this infiltration of the ligaments, and it doesn't cause that pull of the this nipple towards itself. What it causes is it pushes it away from it. So, of a large lump which is pushing it away from the, which is this a large lump which is pushing the nipple away from it, that is a large lump which is not cancer, most likely, right? If it's something pushing towards, pulling towards itself, and the nipple is getting retracted, that is because of malignancy. Again, remember, there could be number of other reasons. For example, some of these things like periductal mastitis. This can also cause inversion of the nipple or retraction of the nipple, right? It's not always cancer. It can also be because of chronic mastitis, or chronic abscess can also do the same thing. And of course, don't forget, the most common cause of retraction is some kind of a congenital reason for it. That nipple in the first place didn't get out of their place under the skin, and they just didn't start functioning the way a normal nipple will be, which is protruding out. So so these will be the things that you would have to consider. And don't forget that even if the nipples are retracted, it doesn't change the T stage of the tumor. Puckering, tethering, and dimpling do not change. So also these ligaments uh, which have become contracted because of the malignant infiltration and pulling the nipple towards itself, that also will not change. So what are the other signs, local signs?
Sir, no dilated veins, sir. No axillary swelling.
Mm-hmm.
No mass or no ulcer, no ulcer seen in the skin, sir.
When we were talking about the ulcer, it's very important for you to remember one thing, that ulcer changes the T stage. How does that ulcer looks like? What could be the cause of ulcer in a patient? What could be the cause of ulcer on the breast? Tell me.
One is inflammatory breast cancer, sir.
Huh?
Inflammatory breast cancer.
Cancer, fungating breast cancer is one thing, which it could always give rise to ulcer. What could be the other cause of ulcerated lesion over the breast?
Sir, inflammatory, sir. Infection, tuberculosis.
Tuberculosis. Don't forget tuberculosis. Tuberculosis is a very common cause of ulceration over the breast, so you don't forget about it.
Sir,
Then, when you
IgM, sir. Idiopathic
when we were
dermatitis.
talking about observation, when we were talking about inspection in the of the patient, while patient is sitting in front of us and we are inspecting, important things that we should always remember is the symmetry, any lump that we can feel, the size of the nipple and the areola, and any local signs that we have discussed so far. And one sign that has been mentioned is pudorama, orange peel appearance. The
Yes, sir.
orange peel appearance is because of
Sir, involvement of the subdermal lymphatics, sir. Involvement of the subdermal lymphatics.
The lymphatics of the skin, they pass through the breast to reach the axilla. So if there is an obstruction to the lymphatics, what will happen? That there will be, cutaneous edema. And cutaneous edema between the skin, between the hair follicles, the skin will swell, but in the region of hair follicles there is no space for the skin to swell, so there would be some kind of a pit that you would see. That is the place of a hair follicle. So in the region of the hair follicle it cannot swell, so therefore there would be kind of a pore there, and in between it can swell, so there is some kind of an edema. So it is called orange peel appearance, or well, the other name for this is peau d'orange. And it is very important. It changes the T stage. It changes the T stage of the disease. It is a sign of the skin involvement. Skin involvement is a T4. And what are those things which make it which make T4 from the skin point of view, skin involvement point of view?
Satellite nodules.
Huh?
Satellite nodules.
Satellite nodules.
Direct any ulceration, sir.
Ulceration and peau d'orange.
Peau d'orange.
So these are three things which make it T4, and this is, I think, T4B, I believe, I have not mistaken.
Yes, sir.
These are the T4B signs come from this. If your patient is having those things that we were discussing, that doesn't change. I don't want to go back to that because we have limited time here. It doesn't change the the T stage. Satellite skin nodule, ulceration, and peau d'orange. Remember all of these things and look for them very, very thoroughly. Another important point, that you should remember, which is Paget's disease. And Paget's disease, what happens?
So it involves the nipples, sir. I mean, there is a discharges from the nipple and the areolar complex. There is a discharge, and there is increased.
It is involvement of the nipple first, then progressing to the involvement of the areola. Remember that. And it results in destruction of the nipple. So involvement of the nipple, destruction of the nipple, and then the disease progresses to the areola. If the disease starts per se from the areola and moves towards nipple, then it is eczematoid or dermatitis type of situation and not a Paget's disease. So when you have a patient, where there's involvement of the nipple, now you have to be very, very sound in finding out whether the nipple started first and then it progressed to the areola, or it started from the areola and then moved over. Eczema can be having bilaterality, whereas Paget's disease is unilateral. It starts from the nipple, then goes towards the skin. So in histological terms, what is this condition? In histological terms, what is this condition?
It's a pre-malignant, sir. Pre-malignant, sir. It's a pre-malignant carcinoma in situ, sir.
No, it is something which is a little different. Carcinoma in situ, somebody has written Mardi to everyone. Anybody else? You can write. Yes. This is an intraductal carcinoma in situ of the terminal ducts, which then involves the epidermis and spreads along the epidermis into the areola. So it breaks, there is, these are ducts are coming and joining the skin, isn't it? These ducts are coming and joining the skin. So this cancer is moving, this cancer is occurring in the terminal ducts. It is an intraductal cancer. It is moving along the ducts and then involving the junction between the duct and the skin and spreads to the areola and then to the nipple and destroy them in the process. So that is what is a Paget's disease. I think all of these things, that we have discussed are important. So when you are examining in this position, so many things, such a wealth of information that you need to collect. So I think the basic idea of this session is to start from the elementary and then to move gradually towards more, more complex areas. So we start with the elementary thing, how to do the examination properly, what to look for, how to take a good history. Then we can always move, towards, more exotic things and more, let's say, those things which are concerned with the management, and those things, where a lot of controversies would come up. But here, we are with those situations, where things are absolutely simple yet important in understanding, and these are the basics.
Yes, sir.
Okay. So now quickly, just when how do you examine the patient's lump? We have examined the breast. How do you examine the patient's lump?
Sir, first the patient was examined in this sitting position, arms by the side. Patient was
No, as
examined
well,
concentrating.
when it comes to the examination of the lump, when you want to know the all the characteristics of the lump. Okay.
Yes, sir.
So when you want to know the characteristics of the lump, patient has to be lying on the couch. You will examine the patient while the patient is lying on the couch, and you will be examining the lump against the chest wall.
Yes, sir.
Then only you will be able to. And then of course you can ask, for example, if you are examining the outer quadrants of the breast, so you'd ask the patient, to be at 15 degrees on the other side, so that the bulk of the breast will fall medially, and then you'll be able to examine the breast on the lateral side. So it's not that patient is lying flat. Patient is lying flat, and then patient is lying 15 degrees against the opposite side, so that you can examine, and the breast falls off to the other side, so that you can examine it thoroughly and establish all the parameters of the lump, right?
Yes, sir.
So, all the characteristics regarding size, shape, surface, and mobility of the skin, mobility over the underlying things, that would be basically requiring you to examine the patient first in the lying the position. And as when it comes to looking at whether the lump is fixed to the chest or fixed to the underlying muscles, that's when of course you would have to get the patient, and will examine the lump with the patient's arm by the side and pressing her hips, and then you can examine whether the lump is moving or not. And especially when these are outer quadrant lumps, where you have to examine the lump for the fixity to the sternum, to the this serratus anterior, you would require another maneuver, right?
Yes, sir.
Whether the patient is kind of pressing against your shoulders, and then you are looking for the movement of the lump, or where the patient is pressing against the wall, and then you are looking for the restriction in the mobility of the lump.
Yes, sir.
So, what is the situation in a patient of breast lump, which is due to cancer? What will be the characteristics?
Sir, it may be fixed to the muscle or the chest wall, sir.
Start from the beginning and go to the
Uh,
advance.
okay, sir. It'll be a stony hard swelling,
It will be a firm to
firm,
hard swelling.
firm to hard swelling.
It will be, first of all, it will be a discrete lump. Now, you have to understand what is a discrete lump. Discrete lump is that you are able to feel it with the flat of your hand. If you feel it between the thumb and the fingers, it is a indiscrete lump. So if you can clearly feel that there is a change between the normal and an abnormal swelling present somewhere, or an abnormal lump present somewhere with the flat of your hand, then only you will call it as a discrete lump. So first of all, it is a discrete lump.
Yes, sir.
Second,
Sir,
it would
any
be
nodes
it will be hard.
hard.
On the surface, it could be irregular,
Yes,
right? Edges, what will be the edges?
irregular, sir.
Hmm?
Irregular.
Edges at times, could be interdigitating with the normal breast tissue, because cancer may be infiltrating. Cancer generally infiltrates into the normal breast, so the edges may not be clearly well defined, but you can have, okay, edges are up to here, but this is not a clear end of the swelling, right? So
Yes.
edges at times may be in ill defined.
Sir, there may be dimpling or
हो गया, वो
tethering.
तो हो गया, हम तो लंप की बात कर रहे हैं.
Sir,
Skin.
associated axillary lymph nodes may be present, sir.
Huh?
Axillary
No.
lymph nodes.
When you move this lump, there is also some kind of a movement of the breast tissue
Yes,
fixed
sir.
to the breast. All breast cancer lumps are fixed to the breast gland. The fibroadenomas and cystosarcomas are mobile lumps. They can be moved extensively from one area to the other, right? They are not fixed to the breast parenchyma. This is fixed to the breast parenchyma. So when you have a lump in the breast, you move that. When you have a lump due to cancer, you move it. The breast, adjacent breast will also move with it.
Yes, sir.
It's fixed to the breast. That's what is the word we use. And then it can be fixed to the skin, as we have already discussed, or it could be fixed to the underlying muscles.
Yes,
So
sir.
how do we know that it's fixed to the underlying muscles or
Sir,
to the
first,
chest wall? How do we know that it's fixed to the muscle or the chest wall?
sir, first coming to each muscle, sir. A pectoralis major muscle. You need to ask the patient to keep the hands by the side and press, sir. On pressing, then you need to palpate the anterior axillary fold, that is a pectoralis major muscle. If the swelling moves a little bit in the perpendicular but not along the muscle, then it is told as it is fixed to the muscle, sir.
That's a very simple thing. You contract first. You know what is the innate mobility of the lump, how much it moves in both the direction, at right angle to the muscle and also in the direction of the muscle fiber. Okay, first you know that. Second is, now you ask the patient to contract the muscle. And how the patient contracts the muscle? She puts her hand on the pelvic
Right.
bone or iliac crest, and you ask her to press the iliac crest, right? And when she does it, the pectoralis major gets contracted, and now you see what is the degree of restriction, right? You can do this sign very well when the patient is lying also, because that's also possible to do it, and it is not difficult to assess that kind of a mobility. Okay.
Yes, sir.
So, and whether the patient has contracted the muscle, you will always check by seeing whether the anterior axillary fold has become taut or not.
Yes, sir.
Done. That's regarding this particular
Pectoral
aspect.
muscle. If it is
There's
serrator as anterior, either to the chest, either the patient pushes towards the chest wall or the doctor's shoulder, and
so
then you examine
these
for the
are the
mobility.
outer. This will be the. These lumps should generally be in which area, which will be fixed to the serratus.
Outer quadrants or upper outer quadrant.
Upper, outer,
Outer,
mostly these are the
lower out,
outer lower quadrant
outer
lumps.
lower quadrant.
Outer lower quadrant lumps are the ones which could be fixed there. So, my dear, I think we've done a preliminary thing, and
Yes, sir.
we've set the ball rolling. As far as this case is concerned, now I think quickly you can just summarize it so that we can give it a final verdict on it.
So I'll just finish my palpation, sir. I mean, a quick. There was a single lump of size 3.5 to 3 centimeter. It was the swelling was firm. It was palpated at 12 o'clock position. Swelling was mobile with having intrinsic mobility.
Why
There is
you never use the word was? It is,
it is
because
sorry.
the patient is in front of you. Never use the word was. Was is only when you have operated or the patient is dead. So here we assume that the scenario is that patient is in front of you and you are presenting to us. So the swelling is mobile.
With
It is
intrinsic
3 centimeter in size. Over surface is smooth or surface is lobulated.
smooth surface, sir.
So and it is mobile swelling. It is not fixed to the underlying
Underlying
muscle,
muscle. Yes, sir. There is
and
no
no skin fixity.
No, yes, sir. No, there is no fixation to skin or the underlying muscles or the chest wall, sir. The patient was asked to bend forward. There is no fixity of the chest wall too. There is no dilated veins. There is
Chest
no.
wall is not seen like that. Chest wall is that you can't move the muscle, can't move the lump at rest. Means that it is fixed to the chest wall.
Yes, sir.
Okay. So
Yes,
what's your diagnosis?
sir. My main diagnosis is fibroadenoma, sir. My differential
Hmm?
diagnosis. Other diagnosis is lipoma, tubular adenoma. Yes, sir. These are my other differential diagnoses. My main diagnosis is fibroadenoma of the breast, considering the age and symptoms.
Why do you make the diagnosis of lipoma?
So that is also a mobile swelling.
Have you seen any patient of lipoma in the breast? In my so many years of experience, I have not seen one.
Yes, sir.
Lipoma can occur under the skin, but not in the breast.
Yes, sir.
We have not seen. No, never make a diagnosis just because you think that it is an exam and I have to impress the examiner. Never make a diagnosis to impress the examiner. Remember this: examiner is far too smart, and he would immediately know tubular adenoma. Have you seen one tubular adenoma?
There
Are
is
you
more of a, I mean,
are you
histological
are you
diagnosis.
do you have microscopic eyes that you can make such diagnosis?
Yes.
So
And
you
fibroadenoma,
say
sir.
that okay, my diagnosis is fibroadenoma. However, I would like to consider the possibility of a cyst in the breast, or I may like to also consider the possibility of cystosarcoma phyloides, because any tumor that is more than 3 centimeter and showing faster growth pace, I may consider that.
Yes, sir.
Okay, so these are things that you have to keep in your mind. Why should
Yes,
you unnecessarily do something, which is just for the sake of impressing the examiner? I tell you, if there's one message that I want to give you to all the people who are attending this class, that please do not make any diagnosis to impress the examiner. Do what you do in an average setting in your hospital. Do what your teachers have been doing and what they have been telling you to do. Don't just be like, okay, today is the day for me to show my knowledge. No, it's not it is application of knowledge that matters. It's not your width of your knowledge, how you apply your knowledge. If, for example, you make an exotic diagnosis, remember, it will make your grave in the exam. Never make an exotic diagnosis. Never make a pathological diagnosis. Never make this diagnosis like, it could be some kind of a vascular malformation of angiomatous hyperplasia, blah, blah, blah. Never. Only make simple diagnosis, and that will be what that is required. Anything else would be subsequent to that. In theory, you can write whatever you want to, but in practice, it is simply like this: whether you have applied your knowledge properly or you have not applied it. What will
yes.
you do for this patient? That's last.
Sir, first triple investigation, sir. First, after examination, I will ask her to do a mammography, sir. And
Why
depending on
mammography? Why mammography? Do you do mammography in a patient of 22 years of age?
ultrasound of at least ultrasound of breast,
Well, you can change like that.
ultrasound.
How do you manage a patient of fibroadenoma in my unit?
Sir, first we do ultrasound, sir.
Huh?
Ultrasound, ultrasonography.
Ultrasound. Ultrasound may where we get the picture that okay, it is a hypoechoic lump.
Yes, sir. Hypoechoic lump.
Hypoechoic, well differentiated lump with no significant increased vascularity.
Yes,
But
sir. Then we go for excision, sir. I mean, we after proper investigations, initial
why do you want
investigation.
to excise it?
Sir, if the patient is feeling uncomfortable, I mean, it is a patient's wish, sir. A patient is cosmetically, she is not uncomfortable, then you excise it, sir.
What is the indication of excision of this lump?
Uh, Sir, one is patient's wish, sir. Whether patient
This lump.
I mean, increase in size, sir.
Uh-huh.
Increase in size.
I think, Sham, your understanding of fibroadenoma is very sketchy because, cancer is all that you've been reading. Fibroadenoma you don't read. in this case, the important thing is that we have to always establish the diagnosis. So remember, whatever the lump, we should always establish the diagnosis before we decide what we need to be doing, right? Second is that if the patient is having a rapidly increasing lump of 3.5 centimeter, it is a marker that the patient has a active fibroadenoma, or what's called as giant fibroadenoma, or it's possible that this may be a this may be a phylloides tumor. So we don't use the word cystosarcoma phylloides, although I've been using it in the past, but we call it a phylloides tumor. The phylloides tumor nowadays is becoming very better understood than it was, and phylloides tumor has many kind of ramifications. So now, we don't leave these tumors just because it is benign tumor. These tumors have a very great possibility at times, to become, sarcomatous and create more problem. So any tumor which is 3.5 centimeter or so should be removed. Only small fibroadenomas, after confirming, you can leave them, and quite a few of these uh, fibroadenomas can undergo natural evolution, and generally after menopause most of the fibroadenomas will become atretic.
Yes, sir.
Okay, so the message that I want to give you to you is, at the parting messages, that please read this topic of fibroadenoma, and in our next class, let's discuss a few aspects of fibroadenoma and phylloides tumor, so that we our understanding of these two topics becomes better. So let our next class be devoted to phylloides tumor uh, and phylloides tumor and fibroadenoma, and let's discuss it for 30-40 minutes. Okay, so at least we are very clear. Clinical we have discussed, so let's discuss a little bit of theory. So I would make a volunteer from anyone who wants to make a presentation, and we should all come prepared and make a good presentation.
Yes, sir.
Thank you, everyone. Sham, thank you, Sham, for
Thank you, sir.
being the sacrificial lamb. Don't mind being tough on you, because if
Yes,
I'm
sir.
tough on you, then only I can get the best out of you.
Yes, sir.
So my
Definitely.
intention is that I'll be a tough examiner, but I'll be tough to the extent that I will always like to give you an answer for whatever questions you have. I'll not sort of leave you in the center and leave you in the lurch. I'll
Yes, sir.
always
Definitely,
give you
sir.
some thoughts, and also always give you some ideas and answers to your queries. But I will also like that, we take these classes with seriousness and with a lot of rigors. So next presentation should be, you decide who will do it, and let's do a good presentation on that. And maybe in the end,